Alright guys, so today I'm going to be talking to you all about the Disorder of Consciousness Scale, also known as the DOCS. So in terms of the clinical relevance of the DOCS, it's a structured clinical assessment tool that's used to detect subtle changes and observable indicators of neurobehavioral functioning during recovery of consciousness following a TBI. It's also used to monitor recovery of consciousness and to evaluate the effects of interventions. It's important to note that there is a new version of this called the DOCS 25, and this is the most up-to-date and current version that's being used currently, but we'll be using the DOCS 23 for the purpose of this video and for the purpose of our class. And this assessment or outcome measure is used mostly in acute care, ICUs, inpatient rehabilitation, LTACs, and SNFs. So the DOCS 23 was designed for patients with disturbances in consciousness following an acquired brain injury or a TBI, and it's used as a bedside assessment. Again, like I said, to identify subtle changes in neurobehavioral functioning during the recovery of consciousness, to track progress and evaluate the effects of interventions used to help with TBIs, and to inform clinical decisions and prognoses of these injuries. So, in discussing the DOCS 23, it's important to note some limitations for the TBI population when thinking about this outcome measure. First, let's talk about fluctuating arousal. So, a patient's level of wakefulness can change significantly throughout the day, which can influence their overall response during this assessment. And failing to account for these fluctuations can lead to inaccurate conclusions and just an inaccurate measure in general. In terms of sensory motor deficits, any underlying sensory motor impairments can interfere with the patient's ability to demonstrate a response during this exam, making this exam kind of invalid in terms of the scoring. And kind of continuing on with that, some medical factors as well. If patients are on sedating medications, it can depress their levels of consciousness. And if they have other injuries, such as spinal cord injuries, or anything that may interfere with a patient's ability to respond, it can make it hard to score this exam as well. And lastly, if anybody with a TBI can obviously have cognitive and language deficits or just with having any other injuries involved with it as well. And these pre-existing cognitive and language impairments, for example, something like aphasia, can make it difficult for patients to actually understand what you want them to do during this test, which can confuse the results of the assessment overall. So now what I want to do is present a case scenario to you guys with the limitations for the population in mind that I just went over. So a 54-year-old female presents to the ICU with a severe TBI after a motor vehicle accident. In addition to the TBI, it has been concluded that the patient has also suffered from a C7 spinal cord lesion. They are currently unconscious and intubated in order to assist with breathing. During their stay in the ICU, they are being treated with sedatives and muscle relaxants. So kind of take a second to ponder on these two questions. Is the disorders of consciousness scale appropriate to administer to this patient, and what factors may limit this patient's ability to engage in the disorder of consciousness scale? So, kind of answering that first question, is the disorders of consciousness scale appropriate to administer to this patient? Most likely not. Again, it all depends on the situation and, obviously not being there in person, but based on the case scenario and the tangibles that we received, it's probably not the best tool to use. And so, what factors may limit this patient's ability to actually engage in the disorder of consciousness scale, or why is this not really appropriate? In terms of fluctuating arousal, obviously the patient is not conscious right now, and so kind of managing the conscious and unconscious and wake cycles that they have is going to be difficult to score on this assessment. The possible sensory motor deficits that are that have arisen due to that spinal cord injury as well can make it super difficult to score this assessment. Them being on sedative medications can alter their consciousness heavily and again make it difficult to score. And then just the possible cognitive and language deficits that they may have acquired due to this TBI. Again, we're not there in person to actually assess that, but it's pretty, we can conclude and make a good hypothesis that they might have some cognitive and language deficits with this post MVA and with the onset of this injury. Good, so moving on to the components of the actual test or the outcome measure in general. Because it's the DOCS 23, there are 23 items on the actual test, so that's a good way to memorize it for the exam and for the practical. The rating scale describes levels of neurobehavioral integrity based on response to test stimuli. And so throughout those 23 items, the patient is kind of asked and put through a bunch of different stimuli, and they're graded based on how they respond to it, which I'll get to in the next slide. It's repeated over time to compare to the baseline assessment. Again, just like every outcome measure, we do We do them so that we can compare baseline and then to how they progress, not only for our objective measurements, but so the patient can be encouraged on how they're progressing as well. And there are seven subscales of neurobehavioral functioning that are included in this version of the docs, with them being 1, social knowledge, 2, taste and swallowing, 3, olfactory, 4, proprioceptive, 5, tactile, 6, auditory, and 7, visual. And in terms of the equipment required for the Docs 23, again, because it is a consciousness test, there are a lot of different subsections and different items that are to be scored. And so I'm not going to read every single piece of equipment required, as you guys can kind of see it on your own screens right now. But as you can tell, just kind of with certain items on this list, we're testing different systems and we're testing different reactions to different stimuli. And so with the feather and different flavors, we can test different systems and different responses to stimuli, and that'll help us kind of score this assessment as a whole. So how to score the test? So a score is assigned to the observed response for each specific test item. The rating scale is on a 0 to 2 scale, and so 0 is no response, 1 is a generalized response, and 2 is a localized response. And in the next slide, I'm going to go over some common errors in scoring and kind of how it can be misinterpreted at times. So in terms of the overall scoring, there's a raw score between 0 and 46, and that raw score is converted to interval level data, and is rescaled on a 0 to 100 point scale just to make it easier to understand. So a 0 is the minimum or the worst score that someone can receive on this test, and 100 is the maximum or the best score that they can receive on this test. So like I said, the higher the score, the better the outcome of this test. So now that I kind of discussed how to score this test, I kind of want to talk about some common errors in scoring the Docs 23. Because it is a test that assesses consciousness, it can be difficult at times to score this test, especially given the patient condition. And so the first one is just mistaking reflexive actions for conscious responses. As we know, reflexes are reflexive, they're involuntary, and they're things that just kind of happen under unconscious control. And so, for example, if a patient may move an eye or a limb reflexively in response to a stimulus, that could just simply be a reflex and not actually evidence of them being conscious. And so that's something to be aware of when you're scoring this exam. Another one is failing to detect subtle signs of consciousness. Again, on the flip side of those reflexes, we do have to make sure that we kind of take into account and give patients credit for just these subtle signs of consciousness that they have. And so something as simple as visual pursuit or purposeful limb movement that can often go overlooked is something that's easily missed in the evaluation or the administering of this test and can actually be scored. And lastly, kind of how I talked about in the limitations in this population or in limitations in this test, motor, sensory, and language impairments must be taken into account. The inability to respond to a command may not be due to their consciousness, but actually may be due to a motor impairment. And so this is something that we need to, as physical therapists, be able to delineate when giving this exam. All right, so let's shift gears and talk a little bit about statistical properties of the Doc 23. And it's important to note that all of the following numbers are for TBI patients in the TBI population, as this kind of pertains to what we're learning. And so in terms of the standard error of measurement, or the SEM, for this outcome measure, it's a 4.14, which is pretty good. All the SEM tells us clinically is the reliability of an outcome measure that quantifies the amount of random error in an individual's score on an outcome measure. And so the larger the SEM, the lower the reliability, and the lower the SEM, the higher the reliability. And so with this outcome measure, we have a pretty low SEM, which kind of indicates a higher reliability and suggests that repeated test scores for the same person would be more consistent. Next, the minimal detectable change, or the MDC with a 95% confidence interval, is a 5.6 for the Doc 23. And all this tells us clinically is the statistical estimate of the smallest amount of change in a score that can be considered a true improvement or decline. And so this can help us see, is a patient's improvement or decline actually statistically significant. Next, the minimally and clinically important difference, or the MCID, is an 8.6 for the Doc 23. And again, this tells us clinically that it tells us the smallest change in a measurement that a clinician, such as us, would perceive as beneficial and important. So a patient would need to either decline or improve by 8.6 points for it to be considered clinically important or beneficial. In terms of inter-rater reliability, the ICC for the DOC23 is a 0.90. And all the inter-rater reliability tells us is the extent to which two or more independent evaluators, or two or more therapists in our case, can consistently produce the same result while measuring the same thing, in this case, measuring the level of consciousness in a TBI patient. And so the higher the inter-rater reliability indicates that two different therapists can likely produce the same result, which is good because, if two different therapists are working with the same patient, we want to be able to see that us as therapists can produce the same score for the patient on this outcome measure. And lastly, the predictive validity. Baseline DOCS23 scores can accurately predict outcomes at 12 months post-injury or 12 months post-TBI with an 87% accuracy. So just kind of like any validity or accuracy percentage, like we've learned in any class, the higher the percent, the more accurate or valid the test is. And so with an 87% accuracy for predictive validity, this is a pretty good measurement for that. All right, guys, so now I'm going to show you guys kind of a demonstration of the DOCS23. And so if you guys have any questions, feel free to let me know. But I'm going to let this video play out for you guys and kind of show you how I would do it clinically and how I've kind of learned through research how to do it clinically. All right, what's up, guys? So this is the Disorders of Consciousness Scale, or the DOCS. This is version 23. So this is a pretty long and extensive outcome measure, because it is testing for consciousness following a TBI. And like I said earlier in my video, this test is mainly going to be done in the acute care setting or an intensive care unit, a SNF, or kind of an LTAC. And so this is for patients who kind of are pretty severely injured. And so this can take up to 40 minutes according to the Shirley Ryan Ability Lab website. And so what I'm going to do is I've kind of linked the form in the discussion post, and so I want you guys to kind of pull that up and follow along as I talk about it. For the first part of this test, it's just baseline observations, and so I'm not going to do this on my patient as I don't want this video to be extensively long for you guys, but we can kind of talk through some of the important parts of this. And so the baseline observation sheet, if you're looking at it in front of you, has a lot of kind of your vital signs that we look at in different classes. And so you want to look at kind of where you're doing the baseline observation at, the time and nature of the previous activity, if you do it in 1 or 2 sessions, just kind of to indicate that part of it. What noise level is the environment in? Is it quiet? Is it noisy? Are there noise interruptions throughout? You want to look at their heart rate, their oxygen levels, and then you want to just see the position of the patient. So for instance, my patient behind me is currently in the bed, lying on her back in the supine position. And I'll kind of take over from here with the spontaneous and random movements. So you want to check all that are observed. So with eyebrow movements, you want to see if the right, the left, or both eyebrows are moving. If they have a frown or a grimace, are they smiling? Do they have any twitching or tremors of the mouth, tongue movements, etc.? You guys can kind of, again, look at that, and I'll let you guys kind of read over that. I'm not going to show you all of that. And then respiration, is it quiet? Is it shallow? Is it fast? Is it striderous? Is it even present at all? With swallowing, again, is it constant? Is it occasional? Is it not even observed? Are they able to drool, or are they drooling? And then an important part of this test I want you guys to kind of think about is the posture. So you want to describe it either as tense, relaxed, spastic, flexed, extended. And you want to look at the posture of their face, the neck, the right and left upper extremities, and the right and left lower extremities, as well as just the whole body in general. And so if my patient here is in supine in a hospital bed, pretend like we're in the acute care setting, I'll kind of want to look at that as well. And again, does the patient wear glasses? So now we're on to visual. Yes or no. You can, if they're not conscious currently, or you think they're not, then you can ask their family members, and then you can see if they're actually being worn during the observation. And you want to look at the level of the light in the room. Is it dark? Is it dim? Is it bright? And then you want to see, kind of observing before you start the assessment, at the frequency of their eye opening. And again, you guys can see on that sheet the various different checks that you can give on their duration and frequency of eye opening. And then the last part of that baseline observation is the eye positioning and movement. And so, do they have nystagmus? Do they have ptosis? Are both eyes deviated in either the left or the right direction? Could you not even observe them at all because their eyes are closed the whole time? and are their pupils dilated or constricted? And so that's kind of the first part of it, is doing a baseline observation. And again, for the purpose of this video, I didn't want to go through each and every single one of those items because I feel like the more important part is actually the stimuli that we're going to give the patient by the modalities, which is the actual scoring part of this exam. And I want you guys to kind of look over that first part on your own and kind of picture how you would do that. All right, so now what we're going to do is we're actually going to run through the docs with my patient here. Kind of the setting we're portraying here is just an acute care. Let's say we're in the intensive care unit. I'm bedside by my patient trying to give them this DOCS-23 outcome measure assessment. And so if you guys want to pull up the sheet in front of you, I'm going to ask some questions along the way as to what you guys would score them to keep you guys interacted and engaged. So for this first question, just the social knowledge items, item 1, I'm going to go up to the patient and say, hey, my name is James Lee. I'll be your student physical therapist today. How are you doing today? Good. And so based on no patient response, what would you guys grade the patient? Would you grade them a 0, which is no response, a 1, a generalized response, or 2, a localized response? Good. I'd give them a 0 as well. And just because they didn't respond to that part of the test doesn't mean they're not conscious at all. It just means that we need to move on and continue to see what parts of their body are conscious. So next, I don't have a cotton tip applicator or juice in general, but what I would do is I would put a cotton tip applicator with some juice on it, and I would just basically, if I'm able to open their mouth and if I think they're somewhat conscious, I would put it in their mouth, and then I would see a response that they give. And like I mentioned in my video, something like a gag response or a swallow reflex is reflexive in nature, and it doesn't necessarily mean that they're conscious, and so we need to kind of use our clinical judgment there as well. And the same thing for the next part of it is just massaging the masseter. And so I'd come up to my patient and I would just touch their cheek where the masseter muscle is, and I would massage it and I'd look for a response. And so again, something like a twitch or a reflex is not normal, but again, if they're awake, if they blink their eyes at me, or if they give me some sort of sign that they are conscious that isn't a reflex, I would grade that a 2 or a 1. The next part of it is the olfactory items, and so you basically just give them 2 odors in front of their nose. So if you guys are looking at the sheet, you write down the name of both odors and you test it on 2 separate occasions. So say for the first one I had a cinnamon odor, I'd write that down, I'd waft it in front of their nose, and again, and if my patient, again, she's smiling here, and so she's smelling something, and so that's more of a sign of consciousness as opposed to just maybe nostrils are dilating or constricting. That could be more reflexive in nature. And you would do that twice with 2 different odors. The next part of it is just passive movement of any joint. And so I could take and pick up kind of her elbow joint, and I would just passively move it back and forth. And again, I'm looking for a patient response, not something that's reflexive. And so if they, for instance, if they twitch away from me when I grab their limb, or if they're trying to fight against me, if I see them voluntarily contract a muscle, these are all things that can indicate consciousness. And I'm sorry, it is hard to show you guys or fake a 0, 1, or a 2 based on this test, but I hope that talking through this is helping you guys somewhat. The next 4 items are just tactile items, or my apologies, items 6 through 13 are all tactile items, and so you would either get air, kind of blowing on them, put a fan on them, a feather, hair, apply vibration to the big toe or the heel, and those are kind of the first 4 for light tactile. And again, you would apply these things kind of anywhere on their body, and so if I, for instance, for item 7 had a feather, I could just lightly touch, again, their hand or their thigh or their leg with that feather and see what kind of response they have there. In terms of the firm tactile response, there's a hand and a scrub, and it's kind of a similar concept there. We're just seeing if they have a response to these tactile cues. And then for temperature, again, hard to show to you guys, but we have kind of one with a swab, which is putting an alcohol swab on their big toe or their heel, and then a cube, putting a cube on their ankle, big toe, or heel, just to see how they respond to those tactile cues. The big thing is you don't, again, reflexive movements in nature don't necessarily mean consciousness, and so that's an important part to recognize while going through this exam, as opposed to something that's actually a conscious movement. The next thing I will demonstrate to you guys is just an auditory item, and so
you're not going to tell the patient that you're trying to startle them, but you're just going to kind of give them a whistle and a clap as items 14 and 15 initiate. And so if I were with my patient here in bed, I would be like, okay, for this next item, I'm going to whistle. And so I just go and see how they respond to me. If there's no response, obviously that'd be a 0. If they have somewhat of a response that you can kind of pick out, that'd be a 1. And then like my patient just did here, she was smiling at me, her eyes are open, and she kind of turns her head towards that noise, then that could be something more conscious, and that could be more of a 2. And item 15 is pretty much the same thing, just with the clap. And so I'd sit here and be next to my patient, and I just evaluate her response to my clap. And so again, my patient was able to laugh and turn her head towards me, and her eyes were open in response to that, and so that'd be a grade of a 2. So for the next thing, what you're going to do, it's more of an auditory localization, so being able to know where that sound is coming from. And for items 16 and 17, you can kind of just say their name and then also ring a bell. Again, I don't have a bell, so I'm just going to maybe make another noise, but it looks something like this. Abigail. Hello, Abigail. So for my patient here, she was able to kind of give me some response, but she wasn't able to turn her head and localize where that noise was coming from. So what score do you think that would give them? Good. I'd also give them a 1. I think a localized response, in my opinion, would be more so turning the head and kind of orienting their body towards the noise, which would be turning her head to the right or towards me. But because she was able to give me just a little bit of a conscious response in response to that, her name being said, I'd give that a 1. And the next one, again, I'd have a bell, so just pretend this is making a noise. Ding, 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 ding. Good. And she started to initiate a head roll towards me to kind of localize where that noise is. And so we'll do it again, but the patient this time will look more towards me. Ding, 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 ding. Good. So I'd give that score of a 2. And as you guys can tell, the difference between this bell sound and how she turned her head towards me as opposed to the previous one when I said her name, it's really that localization of the noise and being able to find and orient herself to where the noise is coming from. And the rest of this 18A and 18B are just kind of giving them one-step commands, and so it's auditory comprehension, being able to understand what you're saying. And so, like I talked about earlier in my video, if a person, for instance, has like aphasia, so Wernicke's aphasia, where they're able to speak but unable to understand what I'm saying, this could be a part of the test that's super hard for them and kind of almost unfair to grade. And so we have to take those things into account. So for instance, I could be next to my patient and be like, Abigail, I would like for you to lift your head up and down from the table. Good. And so she was able to comprehend what I say and was able to do it. So what score would you guys give her? Good. I'd give her a 2 as well. And 18B is the same thing. You can just pick another one-step command that you want her to give, that you want her to perform. So I could just be like, Abigail, would you go ahead and open your mouth? Good. And she was able to do that as well. So she has good auditory comprehension in that case and would in turn be given a score of a 2. Item 19 is all about blinking, and so it's all about the blink response. And so you're basically just looking at kind of their eyes and seeing how their upper, middle, lower, and then left and right eyes are moving. And so if they're able to, like obviously a 0 would be that they're not blinking or moving at all, their eyes. A 1 would be kind of a generalized response as to like, maybe it's a partial movement, maybe it's one that kind of comes and goes every now and then. And a localized response would be kind of good, spaced out blinking for each of these items. And so kind of running through that as well. Again, with item 20, it's also looking at that blink response, but this time focusing on an object. And so you could have them instruct them to kind of look up to the ceiling or look up at a tile. If they're in different positions, obviously with my patient being in supine and in the acute care setting in the intensive care unit, they're in a little bit more of a sedative condition than they would be maybe if they were sitting up and doing this test. And so I could have them and cue them to look at the ceiling, or I could put an item in front of them and just see how they respond and blink to that. Item 21 and 20, item 21, A and B, is kind of like what we did with our vestibular screening, and so it's tracking objects vertically and horizontally. So for this one, I could use my pen if they're in supine, and all I would instruct my patient to do if they're conscious and if they have eye movements is I would be something like this. So, Abigail, what I want you to do is I want you to keep focused on the tip of my pen, and I'm just going to move it, and I want your head to stay still, but your eyes to focus on the tip of the pen. Good. Good. And I could do the same thing vertically, so I would instruct my patient, Abigail, I want you to keep your eyes focused on my pen as I move it. Good. And so for that, again, it's kind of like our vestibular screen. We're just making sure that they have smooth eye movements as we move it, and that they're not, eliciting nystagmus or anything like that. Tracking a familiar face, again, with my patient in supine, and in this case scenario, it would be a little harder. But you can get some like family member that's kind of in the hospital with them, a mom, a dad, a brother, or whoever it is, and you're kind of doing the same thing. So when someone's unconscious, or we suppose that they're unconscious, putting a familiar face to them, may make all the difference. And so, say I was Abigail's husband, per se, I would just kind of, as a PT, direct the husband to kind of stand in front of her, and then I would say, okay, Abigail, I want you to follow your husband as he moves to the left and to the right. And so, moving like that. And then you would also do the same thing up and down. So I'd say, Abigail, I want you to follow the motion of your husband as he kind of moves up and down your body. Good. And just kind of like the object one, we're seeing if they can track vertically and horizontally in that case scenario as well. And the last thing we're going to do, item 23, is just the ability to focus on familiar faces. And so it's pretty similar to item 20 if you want to look back on that sheet, except this time instead of an object, you're kind of putting a familiar face in front of them. So someone that they know, again, a family member, a really close friend, and you're just looking at eye movements between the upper, middle, lower, and left and right eyes and their ability to focus on it. And if you guys notice, that's kind of everything for the Docs 23 in terms of the actual test stimuli by modalities. Again, I apologize, it's hard because I don't have all of the modalities and the stimuli with me here. They're just not available. But hopefully talking through that and kind of prompting you guys to answer some of the grading based on my patient's reaction was helpful. The last part of this test at the bottom is the score form for non-research purposes. And so basically you're just kind of looking through questions 1 through 9 and seeing if they have it or not. So for example, question 1 is it a third nerve palsy suspected? And we know with third nerve palsy it's inability to lift the eyelids, and so if you suspect that, you would just check yes or no. Is cortical blindness suspected, indicating optic nerve damage? Is bilateral ptosis suspected? Is there drooping of the upper eyelid? And items 4 through 9 are kind of just in response to stimuli. So I want you guys to read over those items and just kind of run through those. But again, like I said, this test is one that's pretty extensive. Shirley Ryan says that an experienced therapist should be able to complete this in 40 minutes, and you might not even complete it in one session. So this is something that you might have to do in parts, kind of similar to the Asia like we did with the SCI patients. And so I didn't want this video to be an hour and a half long for you guys to watch me do every single bit of it, but hopefully this was helpful to you. Let me know if you have any questions, and thank you for your attention.
Thank you guys so much for listening to and watching my presentation on the Disorders of Consciousness Scale, or the Docs 23. Hope you guys were able to learn something, and I look forward to practicing this with you guys in class. Have a good one.